So we'll need to get started here. Good morning.
Good morning.
Good morning, Kelly. So we're going to have a little bit of Mary Poppins this morning. I'd like to introduce Dr. Serena Barnhill, who is one of our two outstanding inpatient chief medical residents. Do I need to speak a little louder for you? Perfect. I'd like to introduce Dr. Serena Barnhill, one of our outstanding inpatient chief medical residents. She grew up in Conrad, Montana, where she was the class valedictorian, and went to Montana State University, where she graduated with a degree in cellular biology and neurosciences. Then matriculated here in medical school, and earned so many scholarships and awards, I'm pretty sure we wound up paying her to attend medical school here. She's written had three oral presentations on scholarly work, wrote a review article, and this year has been doing a great deal of scholarly work at the University of Washington in the Pulmonary Critical Care Division. I knew I had something special when I read her bio sketch, and she included two things. The first one showed her trademark sense of humor. She wanted to be a calculus professor when she was in second grade, and she was having a race in her math class doing geometry and arithmetic, and her nemesis, Derek, and she were racing, and she completed the task first, and she shouted, "Done!" Whereupon her elderly second grade teacher looked over at her and said, "Serena, you are not a cookie. You are not done. You're finished." And so Ms. Murphy continues to haunt Serena to this day. The other story is that before Dr. Barnhill became a full-fledged physician, she resuscitated her stepfather. I'm getting a little choked up at this notion. It required quite an extensive resuscitation, and he recovered and had no neurologic sequela, her favorite memory. So I'd like to introduce her on a topic that really has nothing to do with her future career as a pulmonary critical care doc. Happy to say she's going to remain with us as a fellow, and somehow she is going to persuade us that there's a connection between Mary Poppins and her future career as a pulmonologist. So a nice round of applause for Dr. Barnhill.
Thank you, Brad. I can't believe you remembered all those names.
Before we get started, there's just one other shout out. Can I introduce your parents in the back?
Yeah.
Do you mind standing up? We're very proud to have you here, please.
Awesome. Well, thank you, Brad, for that introduction. You'll see that I actually disagree with Mary Poppins, but I still love Julie Andrews. So I'm going to be talking to you today about sugar and metabolic disease. And the specific question that I'm going to be posing is, have excess sugar and processed foods led to our pandemic of metabolic disease? I have no financial disclosures. I tried to get them to serve you bacon and eggs, but they served you donuts and bagels instead. So we're going to start out today with a case. And so this is a case from when I was a third-year medical student rotating in Dillon, Montana, which is a rural area in southwest Montana. And I want to start with this case because this is really what got me personally interested in this topic when I was a third-year student, as well as the doctor that I worked with at the time. So I'm going to frame our presentation today with it. So you're an outpatient clinic. You're seeing a 24-year-old woman. She has a history of high cholesterol, and she's coming into you for follow-up. So her history, she'd actually gone to a health fair a couple of years ago and got a cholesterol panel drawn kind of inadvertently. She'd been following up an iron deficiency anemia, and at that time was noted to have pretty significantly elevated cholesterol levels. She said that she had saw a provider right after this who had recommended her to go on a low-fat, low-cholesterol diet, which was in accordance with the guidelines at the time. So she says for the last 2 years, she's been really great at adhering to this diet. She said she'd cut out eggs, she was using egg substitute, she'd cut out most dairy, she wasn't doing any fatty meats, instead was eating poultry and fish. She had really worked hard to do this. Other notable histories, so she was a runner and had been for years. Only medication was an oral contraceptive. And family history was notable. So mother had a history of high cholesterol, which was diagnosed in her 30s, and the mom had been on a statin for the last few decades. Notably, no cardiovascular disease in the family, despite this history in the mother. Social history, notable for 2 to 4 drinks a week. And then on exam, so she didn't have any xanthelasma, she didn't have any cholesterol deposits in her tendons. She had a really benign physical exam, normal blood pressure, normal heart rate for her age, normal BMI. So here are the labs that she got first at the healthcare 2 years before you're seeing her. And then you're gonna repeat them in the office today, and this is what we saw. So pretty significant. High triglycerides, low HDL, really high LDL. We sent a little bit of a secondary workup just looking for other things that might be contributing, and all of that kind of came back negative. And if you plug her into a 10-year risk calculator, you have to make her 40 in order for it to work, but her 10-year risk of cardiovascular disease is only 0.7%. So I'm going to ask you guys, you're sitting there, you're a third-year medical student, and this is the patient sitting in front of you. What are you going to recommend next? So you can silently answer to yourself. If you're feeling bold, you can raise your hand or both hands. So A, are you going to discuss a low saturated fat diet and a low cholesterol diet? Maybe send her to a dietitian for more adherence. B, are you going to discuss a low sugar diet? C, are you going to initiate statin therapy? Maybe she's not planning on becoming pregnant anytime soon. D, are you going to initiate fenofibrate therapy? And then E, are you going to refer her to lipid clinic? Yeah, I see a few hands for that, and I think that's absolutely reasonable, despite the title of my talk. So I'll tell you, there was discussion about whether she should be referred to lipid clinic for possible genetic familial hypercholesterolemia. But remember, you're in Dillon, Montana, so the closest lipid clinic is multiple hours away, and it's going to take a few months for her to get in to see an endocrinologist. So in the meantime, I'll tell you what happened. So I said this case got me personally interested in this topic. So this is actually very personal. So this was me, and the rest of the story holds true. I was a third-year medical student. I was rotating in Dillon, Montana. And the doctor that I was working with at the time was different than most other outpatient doctors I'd worked with. He was counseling his patients on this low-sugar, low-processed foods diet, and he was spending the majority of his visits doing this. And I got to work in Dillon for 6 months, and so every Monday I worked with him. I saw more and more patients who were either losing weight, coming off of blood pressure medications, coming off of insulin therapy for their diabetes. It was really striking, and so there was something to this. So when I went to see him for an actual visit, and he talked to me about maybe trying out this diet, I said, what the heck, it's going to take me a while to get into a lipid clinic. So I did it. And so for the next month, I had no sugar. He gave his patients this handout. This is just a cutout, a portion of it. But really the things that it advised to avoid were things with sugar and things that were processed. So I worked hard and I did this diet for the next month. My favorite part that's included in his handout is this clip that says, wine and liquor may not affect your insulin levels, but they're going to decrease your inhibitions and will throw you off track with your food choices. So I gave up my 2 to 4 drinks a week, and I did this for the next month. And so this was 1 month later. We checked my lipids at the hospital there, and they had come down. Notably, my triglycerides had the greatest response. My HDL went up a little bit. We actually weren't sure what was going to happen with my LDL because this diet doesn't always cause drops in your LDL, but mine came down a little bit. So I was encouraged, and I stuck with this for the next 5 months on into my 4th year of medical school. And this was my panel 6 months after I started the diet. So this was the best it had looked in over 2 years. And I was really curious, I was encouraged, but I had a bunch of questions. And the first one was, why had I been recommended a low-fat, low-cholesterol diet for the last several years, and why were we still recommending that to a lot of our patients? My second question was, what was sugar actually doing in our bodies to cause these metabolic abnormalities? And then third, I was going to be a doctor in a year, so what recommendations should I be making to patients? So that frames our objectives for today. I want to go through our really controversial history of dietary recommendations for the last 50 to 60 years, notably those surrounding fats and carbs, because it's been kind of a whirlwind and it's shifting. Next, I'm going to discuss the mechanisms by which sugar can inherently lead to metabolic abnormalities, and this is despite the extra calories they provide. Third, we're going to go into the diet intervention studies. We're going to see what they show about added sugar and metabolic abnormalities, and then I'm going to discuss future research that I think is needed because I don't think we have the best research yet. And last, to make this practical, for those of you who buy into this, which I'm hoping it's all of you, I'm going to propose some practical recommendations for your patients that you're seeing in clinic every day. So let's get started with our history. So our history is really one of two competing hypotheses. So starting in the 50s, there was the fat cholesterol hypothesis and the carbohydrate insulin hypothesis. We're going to start with the fat cholesterol hypothesis. So this really arose in the 1950s with something called the diet heart hypothesis, which said if we eat a meal that's high in fats and cholesterol, what will happen is that our blood cholesterol levels will rise. This in turn will lead to deposition of cholesterol and plaques in our various arteries. And then ultimately, we're going to get narrowing, cardiovascular morbidity, and mortality. So it's very logical. You can just imagine eating that big, juicy steak on your plate that's just covered in a layer of grisly fat and watching that go directly to your arteries, blocking them up and causing heart disease. So this made sense to people. And there was some literature to support it at the time. So in the 20s, there was a Russian researcher who actually fed rabbits these really high cholesterol, high fat formulations for a period of weeks. And what he saw was that the rabbits' cholesterol went up, and then on autopsy, they had significant atherosclerosis throughout their whole body. They had cholesterol deposits everywhere. Never mind that rabbits are innately herbivores, but regardless, we had an animal model. So the hypothesis really got active in the 50s through the 80s, and it was led by this man, Dr. Ansel Keys. So Ansel Keys was a physiologist at the University of Minnesota. And arguably one of his most famous studies is something called the 7 countries studies. It's cited over a million times in multiple cardiology and diet papers. So this study compared over 13,000 men from 7 different countries, and it looked at their diet and then their levels of heart disease, and it followed them for years. So what Ansel saw was that in these 7 countries, when the percentage of calories from fat was increased in the diet, there was a rise in heart disease incidence. And it's a pretty close association with an R value of 0.84. Now, this study had its critics because remember, about half the research community believed in a different hypothesis at the time. And some of the critics said that Ansel had actually studied 22 countries before publishing this paper, and so there was a question of why all these countries weren't included. Countries like West Germany and France, they actually have very high saturated fat in their diet, but relatively low cardiovascular disease. So there was some skepticism of why this was limited to the 7 countries. More importantly, though, in 1999, so Ansel and his research group had actually collected data on multiple facets of the diet, and they had collected data on sugar consumption, which was a little bit rare at the time. Not sugar consumption, but collecting data on it. So this group went back in 1999, and what they saw was that if they looked at sweets and the association with heart disease, the R value was nearly identical to what it was for fats. So was it the fats in the diet that were causing disease? Was it the sugar? This is far from causal. Despite this, an ongoing huge discord in the diet community, Ansel Keys gets enshrined on the cover of Time magazine in 1961. And he's kind of put up there as the face of dietary wisdom. And if you think about the time period, we had a lot of Americans that were dying of heart disease. And so there was this big jump on his research that started to show this association to try to do something about this huge heart disease epidemic. So he's quoted in this article as saying, the ideal heart-healthy diet would increase in the percentage of carbohydrates from 50 to 70%, while decreasing the percentage of fat from 40 to 15%. So for subsequent decades, Americans tried to do this. Fast forward to 1980. And this is important because this is the first USDA dietary guidelines that we have. And one of their 7 directives, number 3, is to avoid too much fat, saturated fat, and cholesterol. Now, there was ongoing controversy, and it's stated pretty clearly in those guidelines. So I took this from the actual 1980 guidelines. It says, there's controversy about what recommendations are appropriate for healthy Americans. But for the US population as a whole, reduction in our current intake of fat, saturated fat, and cholesterol is sensible. So this is not based on strong data. So we go to 1984 and we have our second Time magazine cover. And this time it says, sorry, it's true, cholesterol really is a killer. No whole milk, no butter, no fatty meats, fewer eggs. So what spurred this? So this cover came after an article published in JAMA in January of 1984. And this was a trial called the Coronary Primary Prevention Trial. So what this study did, it was interesting, it compared 3,800 middle-aged American men. And these men were felt to be at high risk of heart disease. They based that on a total cholesterol level that was greater than 265. So they felt like, based on what they knew at the time, these men with these really high cholesterol levels who had not yet had any heart disease were at very high risk, and they wanted to study these men over the next 10 years. So they split the men into two groups, and I'll tell you about the differences. So one group was given a low-fat, low-cholesterol diet and counseling on that. They saw a dietitian, and they were given a placebo pill. The other group was given a low-fat, low-cholesterol diet, counseled on that. They saw a dietitian, and they were given cholestyramine. So I want us to just pause and recognize the difference between the two groups. So they were not different in the diet that they were recommended. They were different in the drug that they were given. So this was a drug trial, not a diet trial. So what did it show? So the results revealed that indeed, over the period of 9 years that they followed these men, there was less incidence of MIs in the men that got cholestyramine as compared to placebo. But again, this is a medication trial, and both sides were on a low-fat, low-cholesterol diet. Not only that, but these recommendations that Time magazine was saying, no whole milk, no eggs, no dairy, are based on this group of only men with cholesterol greater than 265. So the generalizability to the public is not there. So because of this, we start seeing the food industry make low-fat everything. And what happened was, in order to make the low-fat even remotely palatable and not taste like cardboard, they had to add a bunch of sugar. So America's sugar consumption from the 1980s on just took off. Fat actually plateaued and even came down a little bit, but sugar consumption went way up. And then what we saw is something that you guys can all relate to. We had increasing diabetes, increasing obesity, and heart disease remained the #1 killer in our community. So then we get to 2014, and this is our last Time magazine cover. So this time, they're telling us, eat butter, society's labeled fat the enemy, why they were wrong. What? What spurred this? I would be mad if I had been working on a low-fat. I was on a low-fat diet. So this came out after two very large meta-analyses were published, one in 2010 and one in 2014. And the one I'm going to show you is from 2010. So in this meta-analysis, what they looked at was a bunch of trials that looked at saturated fat association with cardiovascular disease. So just to orient us, so anything to the right, trials to the right, the saturated fat caused a higher risk of cardiovascular disease, anything to the left, a lower risk. So first, when they looked at just coronary heart disease, what they saw was no association with fats. Then they decided to look at stroke. They were reaching. And what you see again is that there's no association of saturated fats with stroke, even potentially a trend towards less stroke in these patients. And then finally, if you look at total cardiovascular disease risk, again, we have no association. So both this meta-analysis and the one in 2014 were what prompted the article in Time magazine. So that's our history of fats. And now we're going to step into the history of carbohydrate insulin hypothesis and talk about what the other half of researchers believed over the last 50 to 60 years. So this hypothesis really started, interestingly, from the observations of missionary physicians who were working in native populations that had not yet been exposed to a Western diet. And so what they saw was when the Western diet came over to their areas, and this inevitably included things that wouldn't spoil while it was getting transported. So it was things like sugar, molasses, flour, lots of carbohydrates and sugars. And it was then their observation that after a certain number of years of incubation time, their population started developing these quote-unquote Western diseases. So they started getting obese, they started developing heart disease, they started developing diabetes. And so there was a concern that maybe it was the consumption of sugar or carbohydrates in the diet that were instead leading to these quote-unquote Western diseases. It wasn't until later and we'll talk about this in the second objective, where insulin resistance gets added to this hypothesis as a potential mechanism for how this could occur. So similar to Ansel Keys, there was multiple researchers who propelled forward the carbohydrate insulin hypothesis, and one of those was Dr. Peter Cleve. So this was an interesting gentleman. He was a retired British Navy surgeon, and what he did in his retirement was he became this obsessive letter writer, and he sent letters to physicians all across the world that were working in these populations that were getting exposed to the Western diet for the first time, and he asked them to write back and tell him what diseases they were seeing in their populations. And they did. And so when Cleve looked at this data, what he saw first, interestingly, was that as soon as they were exposed to our Western diet, they started getting dental caries. They started forming cavities, and that was the first time they'd really had these in their populations. And then after a certain incubation period, again, like other colonial and missionary physicians, he saw diabetes, heart disease, and obesity. So Cleve actually hypothesized that all of these diseases had a single cause, and it was the introduction of sugar and carbs in the diet. In 1956, he published a book stating this hypothesis, which was called the saccharine hypothesis, not saccharin. And this is a chart I took from his book. So this is interesting. So what Cleve did was he looked in England and Wales from 1900 to 1950. He mapped out the sugar consumption in the countries with the diabetic mortality. And what he saw was that they tracked very closely, so sugar consumption in the dotted line. And then, interestingly, during the wars, when they had to ration sugar and other easily digestible carbs, what would happen is the population sugar consumption would go down, and then shortly thereafter, diabetes mortality would fall with it. And so this was kind of his concern, that there was something going on with our sugar consumption that was leading to things. It's interesting. This is in 1900 that he did this. So around the same time, researchers are also first able to separate out the different components of the cholesterol panel. And what they saw, this is from an article in 1957 in a group of coronary patients. What they were able to separate out at that time was total cholesterol, free cholesterol, phospholipids, and triglycerides. And up here, you can see that there's different components of fat and carb and protein in the diet. So I'm going to bring your attention to the middle column. So in patients with underlying heart disease who were given a diet that was 75% carbohydrates and 10% fat, what Ansel Keys and his research groups were recommending at the time, they saw this huge jump in triglyceride levels that they didn't see with other components of the diet. So there was some speculation that maybe carbohydrates or sugar might be leading to rise in triglyceride levels. 2 years later, studies began to show that it was actually patients' triglyceride levels, or at least some portion of the cholesterol panel that tracks with your triglyceride level, that was associated with increased risk of heart disease. So in this study from 1959, what they did was they looked at, I'm going to orient you a little bit because these are not charts that we usually publish today. So here at this blue line is what they consider the normal triglyceride level for the population, and then it's split up into the various age groups. So normal patients, patients without heart disease, you can see their range of triglyceride levels here. And then patients with heart disease, their triglyceride levels were higher. Their range was much higher. And so there was some concern that triglycerides, or something that tracked with them on the panel, was actually more associated with heart disease, and that this could potentially be from a sugar or carbohydrate diet. So now we get 1980, and a Stanford endocrinologist by the name of Gerald Raven. So what Raven proposed was something called Syndrome X. And what Syndrome X was, is what he used to describe the different metabolic abnormalities that he was seeing in his patients that were obese, diabetic, had heart disease. He kept seeing the same metabolic abnormalities track in these groups of patients. And what he postulated was that these were all a consequence of underlying insulin resistance. So what were these metabolic abnormalities? We had abdominal obesity, hypertriglyceridemia, low HDL, hypertension, and hyperglycemia. So this is what we now call metabolic syndrome today. So this was huge for people who believed in the carbohydrate insulin hypothesis, because they finally felt like they had a mechanism by which sugar or carbohydrates could cause all of these different metabolic abnormalities. It wasn't until 2001 when the National Heart, Lung, and Blood Institute actually recognized metabolic syndrome as we know it today. So it took 20 years after Raven proposed it. And from the 2000s on, we had this explosion of evidence. So I've got the trial cited at the bottom of the slide, but what we saw is observational data, epidemiologic evidence for added sugar or sugar-sweetened beverages causing unfavorable lipid levels, insulin resistance, fatty liver, type 2 diabetes, cardiovascular disease, metabolic syndrome, and visceral adiposity. So the next question is by what mechanism is sugar able to induce metabolic disease in people? All right. So first, in order for us to discuss the mechanism, I want you to know what I mean when I'm saying the word sugar. So what I mean is the non-natural or added sugars that have been put into our diet by the food and beverage industry. So this really boils down to two big things, sucrose and high fructose corn syrup. Both are composed of fructose and glucose, the only difference being that sucrose is 50-50, and high fructose corn syrup has about 55% fructose and 45% glucose. And the reason this is because fructose is actually the sweet component, and so that made high fructose corn syrup a little sweeter, and it turns out it's much cheaper to make and to put into products. What I'm going to argue is that while fructose is mechanistically the villain in this story, it's actually the combination of fructose and glucose together that end up being truly harmful. So let's talk about metabolism. So when you ingest sucrose or high fructose corn syrup, what happens to the glucose portion? So right away, glucose works to raise your blood sugar levels, which signals your pancreas to release insulin. And what insulin is going to do, it's our fat storage hormone. It's going to tell us to store all that extra energy as fat. And over time, with high doses, what's going to happen is this can lead to weight gain. Now, about 20% of glucose, and it depends on your energy storage at the time, but about 20% is going to go to the liver. And what happens to glucose in the liver is that a very small amount goes to the mitochondria where it's metabolized. The bulk of it is actually stored as glycogen, and that's through the action of insulin, which it caused an increase in when you ingested it. Any excess above and beyond what goes to glycogen or the mitochondria is going to be converted into triglycerides. So in general, what I want you to take away from glucose is that over time, in large amounts, it can cause us to gain pounds and have abnormal lipid levels, but it's not going to make us metabolically sick in the short term. So that's where fructose enters in. So how is fructose different? So fructose, unlike glucose, goes directly to the liver. Almost 100% of the fructose you ingest goes right to the liver. You get a huge bolus. And what happens with fructose in the liver is that it doesn't have a storage form like glycogen, so all of it's going to go to the mitochondria. And this fructose overload results in excess substrate. It ends up being acetyl-CoA that then leads to de novo lipogenesis, new fat formation in the liver. This then directly increases your liver fatty acids and promotes VLDL formation and triglyceride formation. They export out the triglycerides, and this can lead to dyslipidemia. Increased levels of liver lipids have then been shown to induce liver insulin resistance, and this is by activation of a liver enzyme, NPKC, which ultimately inactivates a key messenger in insulin signaling. So with fructose, we get increased liver fat, dyslipidemia, and liver insulin resistance. Now you'll remember that in order for glucose to be metabolized and stored as glycogen in the liver, you need insulin. So with increasing liver insulin resistance from fructose, what happens is this step really can't happen and can't happen effectively. So all of that glucose is then going to get shunted towards the mitochondria and towards fat formation instead of towards glycogen. So now we have both fructose and glucose are components of sugar, adding to de novo lipogenesis, more triglyceride and VLDL production, and more insulin resistance, and we get this vicious cycle. So in summary, fructose is the one causing the insulin resistance and our inability to store glucose as glycogen. The combination is increasing our liver fat together and kind of perpetuating the cycle. So do we have studies to support this? We do. So there's 3 that are cited at the bottom of this slide, and these studies were designed in that they looked at individuals who were given fructose-sweetened beverages versus glucose-sweetened beverages. And between these 2 groups, they looked at a bunch of different metabolic parameters. And what they saw was that in the fructose group, we saw all of the things we just discussed in that mechanism. They had increased fat formation, increased dyslipidemia, they had reduced insulin sensitivity, interestingly had increased uric acid levels, and then a lot of weight gain. The glucose group had similar weight gain, but they did not have any of these metabolic changes. So what they came to conclude is that fructose has negative effects on the liver, which are weight independent. So not just extra calories, adding weight causing these problems. There was something inherently toxic about the fructose. But now the question is, we've got liver insulin resistance, we've got a little bit of dyslipidemia, but how do we actually get to metabolic syndrome? So here's one postulated scheme in the literature by which it occurs, some of which I'll tell you has been shown in humans, some of which has still only been shown in non-human primates and in mice. So with increasing liver insulin resistance, our liver isn't transporting energy effectively, and our pancreas has to respond by increasing the levels of insulin, so we get hyperinsulinemia. With these elevated insulin levels, what happens is we cause further energy deposition into our fat cells, which leads to obesity, notably abdominal obesity. High insulin levels also act on blood vessel smooth muscle cells to cause them to grow more rapidly. We get tightening of our arteries, and this promotes hypertension. With increased liver fat, as I said before, the liver is trying to get rid of it, and it exports it primarily as triglycerides, so we get dyslipidemia. Triglycerides, or free fatty acids, that are then exposed to vasculature will cause intramyocellular lipid accumulation, so fat accumulation in muscle cells, which has been correlated with whole body insulin resistance. And then last, as this insulin resistance worsens, our pancreatic beta cells eventually can't meet up with the requirements our body needs. We get relative insulin deficiency, beta cell death, and type 2 diabetes. So as you can see, what we're left with are all of the components by which we define metabolic syndrome. All right, so what I've now covered is solid epidemiologic evidence and a plausible mechanism, but the real question is what do the diet intervention studies show? So let's go into that. So in first approaching the literature, I tried to look for systematic reviews and meta-analyses, feeling like those would give me the best evidence. And what I did was I looked at studies that looked at the effect of added sugar on different metabolic parameters. So whether that was on blood pressure or visceral adiposity or insulin resistance, dyslipidemia, all of the components of metabolic syndrome. I then created this diagram to try to sort things out because there's a lot of them. And I'm going to separate them into those that said that fructose led to metabolic disease or changes in our metabolic parameters and those that did not. So at first glance, the majority of studies actually concluded that fructose did not lead to metabolic disease, 9-4. So then I got to looking at the studies further, and I found that a large number of the studies concluding that fructose did not lead to metabolic disease were actually funded or supported by the sugar industry. So whether this was Kellogg, PepsiCo, Coca-Cola. So I decided to exclude those meta-analyses and systematic reviews because I felt like there was a ton of confounding and it wasn't answering the question that we had. So goodbye, sugar industry. What happened was this. So now the scales are tipping in the other direction, supporting fructose leading to metabolic disease. Not all, there was this one holdout. However, as excited as I was to see this once I eliminated the sugar industry confounding, my enthusiasm was very short-lived, and I'm going to tell you why. So for those of you who have looked at any diet intervention trials, this is going to sound very familiar. So there was huge limitations, even in the studies that supported what I truly believe, in the trials that were included. So first off, a lot of these trials were done on an average of 2 weeks. And so thinking about metabolic syndrome and how long it takes to develop, it's hard to make conclusions in a 2-week trial. So I think the longest I could find was 10 weeks in duration, but I felt like this was a huge limitation. Number two, the trials that were included were done in really select populations. So sometimes there would be a total N of 20 people, and they would be all healthy, white 20-year-old men, or all very unhealthy 60-year-old diabetic females. So there weren't any that were really generalizable to the US population as a whole. Third, there was some where the amount of sugar that they were giving participants in the trial was way above what we would actually consume on average in the US. So right now, on average, we consume about 15% of our calories from added sugars in our diet. And some of these trials included doses of like 30 to 35% of total sugar. So maybe 90% or 10% of people actually ingest that, but most of us do not. It was also limited by hypercaloric fructose consumption. So what I mean by this is that they took people with their normal caloric intake and then they gave them a bunch of sugar above that, just adding to their calories. So it really clouds the question of, is it actually the sugar that's causing the problem, or is it just that we've given them twice their normal number of calories? And then last, some of the studies, notably the ones that had null results, compared fructose in one group to sucrose and high fructose corn syrup in the other. So both of those contain fructose, so any null result is not really helpful. So it's disheartening. I really didn't find one trial where I felt like it was done well. I'm going to propose the ideal diet intervention trial, and this is what I think we need to really settle this controversy in the literature, because if you read these trials, there is huge controversy over whether added sugar is actually causing disease. So number one, no funding from sugar industries. That should just be obvious. No sponsorship, no conflicts of interest. Number two, I think we need trials that are of a significant duration. What I propose is 6 months. The reason being, if you remember my cholesterol panel, it took 6 months on this diet for it to really look better. And so I think we at least need trials that are 6 months in duration to see an effect. Next, we need a generalizable population that we can then make recommendations to our own population with. So men, women, different ethnicities, different disease states. Next, we need them to consume fructose in these trials in the ways in which we actually do it. So none of us actually consume free fructose. We ingest it as either sucrose or high fructose corn syrup. So we need our studies to put that into the diet so that we can actually see what the effect is. Fifth, we need a range of added sugar consumption. The reason being, right now we have different guidelines in different societies recommending what's a safe amount of sugar in our diet. So some say 5%, some say 10%, some say 25%. So it'd be nice to have some doses that were actually tried so we can make better recommendations. And then last, the sugar has to be added in as part of a balanced diet. This can't be just hypercaloric added sugars, because then it's hard to tease out whether it's the extra calories or the sugar themselves. And I know I said last, but there's one more plea that I would have, is that they keep the level of fat and fiber the exact same between the two groups when they're studying this, because there's a lot of argument that in diet studies that when you add something in, you inherently have to take something out, and so maybe it was actually what was removed that was causing the problem. All right. What I've shown you is that we've got strong epidemiologic evidence, we've got the plausible mechanism, we have terrible trials, but if you take out confounding, we have some support for fructose leading to metabolic disease. So now let's talk about practical recommendations for our patients. So what I'm going to show you is kind of a stepwise approach and what I think might be helpful. And it's going to start out with what I think is the biggest bang for your buck when you're counseling your patients. So what should you do first and try to do with patients? Then if they're able to do that, you can kind of move stepwise down through this approach to keep eliminating sugar in their diet. So number one is to cut out the sugared beverages. This is 50% of our added sugar consumption. It comes in the form of our beverages. I think our patients, and actually sometimes we, believe that this is all soda. So it's great when you can cut out soda. But it turns out that the average juice actually has more sugar in it per cup than soda does. So when you're talking about sweetened beverages, you need to be talking about juices, notably concentrated juices. You need to be talking about Gatorade, sweetened teas. Those all have a ton of added sugar in them. If your patients are able to cut out those sugared beverages, the next thing I would urge you to do is actually tackle breakfast with them. So in America, breakfast tends to be a high sugar affair. We all just ate a bunch of donuts and bagels and put a lot of creamer in our coffee. But it's true, this tends to be where we get the most added sugar in our day. So if we can get patients to take away their cereal, the donuts, the bagels, we can kind of get them on their way. One other misconception that I'll just point out is that I have a lot of patients who eat the Chobani or the Yoplait with a lot of fruit in it. And it turns out that these have like 15 grams of sugar or more. So they're actually not doing anything much more healthy than that bowl of cereal that they just had. If they want to do yogurt, because yogurt is healthy, they've got to do plain yogurt. And then you can sweeten it up with berries or you can put nuts on it and you can make it fun. Number three is actually to have them avoid nutrition labels. So this is really hard. If you even go into that middle section of the supermarket, you are going into an area where there's only products with nutrition labels, and so if they can stay around the periphery, that's advisable. In general, if a product has a nutrition label, by definition, it's processed. So if they can cut out nutrition labels, they're doing a huge service to their sugar intake. Fourth, if they do buy foods with nutrition labels, because it's almost impossible to avoid, what I would at least recommend is that sugar isn't listed as ingredient 1, 2, or 3. So it can be number 4, but it can't be 1, 2, or 3. And it sounds easy. You just got to flip it around, look and see if sugar is on there. The problem is that the food and beverage industry has gotten really good at hiding sugar. So there's over 40 different names for sugar, and I listed them through M here, and I may have missed some. So you have to tell your patients and give them a list of these extra names of sugar that can cause problems. Fifth, if they're able to cut out white things, white grains, so white rice, white bread, things made with white flour, that's also going to help out their overall sugar intake. And then what I'll just tell you is beware of any foods or packaging that makes health claims. So specifically low fat and fat free. So like I told you before, in order to make these palatable, you have to add a ton of sugar. And so if they're eating low fat and fat free, they're probably taking in more sugar than they think they are. My favorite example of a product claiming fat free, which I think we should not equate with healthy, is gummy bears. So these are fat free, but we shouldn't be eating them. So in summary, what I hope you took from this talk, and actually what I showed you in this talk, is that we really focused on fat for over 50 years. I think this was, in general, largely misplaced, and it likely led to our increased sugar consumption. Number 2, fructose and glucose, added sugar, work to elevate our insulin levels and overload our liver with carbohydrates, and this is truly a lethal combination. Diet trials are terrible. They're limited by duration, higher than average sugar doses, and most importantly, sugar industry confounding. I think we can use a stepwise approach for our individual patients to help them cut out sugar. So in conclusion, a summary is different than a conclusion, I learned in preparing this talk. Sugars are harmful. I really believe that. We need better trials. I showed you what my ideal trial would be. I think we can work to counsel our individual patients in the exam rooms, but ultimately, this is a public health arena intervention. We need to hold our food and beverage industry accountable for what they're putting in our foods. We need the foods that we want people to be eating not to be the most expensive foods, and we need them available in areas that are low income and not these processed foods. So with that, I'm going to thank Dr. John Madney, who was the physician and was in Dillon, Montana, who got me interested in this topic and is still super passionate about it. Michelle Rappaport from the UW Neighborhood Clinic in Belltown. She is a big promoter of this diet. Dr. Anna Walt and Dr. Bremner for helping me prepare in their different ways for this talk. My co-chiefs who are awesome and have been really supportive this year, but notably while I've been super stressed about preparing this grand rounds. And then my husband Caleb, who could give this talk today because I have recited it to him multiple times. And just to end this sugar talk with something that's truly sweet, but it's not going to hurt you and not going to lead to metabolic syndrome. This is my puppy Millie. I'll take questions at this time.
All right, wonderful presentation, Dr. Barnhill. We have a couple moments for questions before we have an awards presentation, so happy to pass the mic around. Yeah.
I've always wondered about the vegan diet, which is quite high in carbohydrates, but also has lower cardiovascular risk, and I wonder if you came across that in your research.
Yeah. So I didn't look at the vegan diet specifically, Shada, but what I'll say is it depends on the carbohydrates that you're taking in. And so if you're doing the vegan diet and you're avoiding a lot of the simple carbs and the sugars, I could see where they would come to that claim. And I didn't look at any papers for it. What I'll tell you is most of the papers that support a certain diet are all observational and not actual randomized controlled trials or diet intervention trials. So I think it's harder to avoid sugars on the vegan diet just because you're already limiting some of the things that you're taking in. But I would propose that if they saw good results, it was because they took in little sugar. I don't know that. Dr. Kaplan.
What is the link to the elevated uric acid level from a high sugar diet?
Yeah. So I actually don't know the physiology to explain why the uric acid levels go up. I think that there is physiology to support that. I just didn't look into it well enough. But what I'll say is it makes sense because you think about your patients with metabolic syndrome that come in, and not only do they have obesity, diabetes, and heart disease, but they have gout and really high uric acid levels. And I think it's a mechanism from sugar. I just don't know the actual mechanism.
There was a question over here.
I was wondering about fruit, unprocessed fruit.
Yeah.
Are there fruits that are recommended? I know bananas and grapes, I think, have quite a bit of sugar.
Yeah.
And it's got fructose in it, so.
Yeah. Oh my gosh, you're a beautiful plant. Thank you for that question. So I will tell you that fruit is different in that it has a lot of fiber in it. And so what fiber does is when you ingest it, it kind of lets out the release of fructose from the fruit in smaller boluses, so you don't get this huge high insulin spike. So I actually think that fruit is different than fruit juices. However, I will tell you that if you're going to reach for fruit, the best ones are actually berries. And that's why I had that picture of putting the berries on the yogurt. It turns out that bananas and grapes actually are pretty elevated. And so I think fruit is okay, especially in the context of everything else we put in our bodies. But the best fruits tend to be berries.
So especially since you said 50% of sugar consumption in the diet is coming from beverages, so an easy switch for people is to switch to sugar-free beverages or artificial sweeteners.
Yeah.
And so I don't know if you came across any thoughts around that. I know that there's some thought that those can also elevate insulin resistance.
Yeah, I think it's a good question. So that's the real question, right? Like we get them to stop the Coke, but is Diet Coke any better? I think, so there's been a lot of literature around artificial sweeteners, and I don't think that we have an answer as to they are completely harmful and they are not. But what I'll tell you is I think I would just recommend if your patients are cutting out sugared beverages, have them do water and whole milk and coffee that's black and herbal teas, and maybe not recommend diet sodas, just because I think that I don't know what's going to be the results of these trials in the future and whether those artificial sweeteners are harmful. Yeah.
Yeah, very nice talk, thank you. Do you want to comment on the allegations that the sugar industry has actually suppressed the scientific evidence in favor of this? And you don't have to talk about it if you don't want to.
Yeah. I'm being recorded.
But you're among friends. So.
That is the allegations, and it's actually similar to the lung cancer controversy that went on decades ago, that they were also suppressing data, and what eventually ended up happening was that the tobacco industry then provided the funding for our government to do better trials that weren't directly supported by the tobacco industry, and I think that's what we need, but there is some strong support and suspicion that a lot of these trials have been suppressed by the sugar industry. Yeah, Dr. Freddy.
What are your thoughts about the sugar beverage tax? Will that help us?
So I think that's hard, right? Because the people in our population who tend to drink more sugared beverages are the lower income, and so we're then taxing the lower income on what they're taking in. So I don't know if I have a feeling about it. I feel that it's at least nice that we're trying to do something to limit the amount of sugared sweetened beverages in our population. Whether that's the right move, I'm not certain. Okay. I don't want to cut too much into the awards time.
We're actually waiting on
Oh.
the arrival, but yes, so one more question. Go for it.
So where does exercise fit in all this?
Yeah. Oh, so you need to exercise. So Truly though, so that's going to be, so all of the sugars that you put in your diet are going to cause all of this weight gain and all of these things, but the thing that we've seen that actually makes you live longer is exercise. So while you might not get metabolic syndrome, exercise is what's going to help you to actually increase your longevity, and it's going to help you use the sugar that you get more effectively. So it's huge. Like, you can't just cut out sugar and be healthy, you have to be exercising as well. Do you have a specific question? I don't have any regimens.
No, it doesn't show up that often in the studies, or actually in medicine grand rounds for that.
Yeah.
It's just interesting.
Yeah, no, it's huge. And it's actually, it's the only thing that's been linked to raise our HDL too. So, great. All right, thanks.